Melancholia is a particularly debilitating form of depression. Dr. Phil Mosley has been seeing this in his patients for years. He and his team wanted to demonstrate the biological difference in this subtype of depression and the need to personalise the treatment.
This is a QIMR Berghofer Medical Research Institute podcast.
Dr. Phil Mosley is Director of Psychiatry at St Andrews, researcher here at QIMR Berghofer, and joins me right now in the podcast seat. Thanks for coming in, Phil.
Thank you for having me.
What inspired this study?
Depression is an awful illness that isolates people from their family and friends, impacts their ability to work and study, and is a cause of great misery. One of the aims of our group here at QIMR Berghofer is to help these people to find effective treatments so that they can recover and live meaningful and fulfilled lives. As a psychiatrist for many years, I've been aware that there are a group of people with depression who don't seem to respond to conventional therapies, so standard antidepressant medications or engagement with a psychologist. And for some time, over 10 years, I've had this theory. It's not purely my own theory, of course. It's a theory that I've developed in combination with other experienced psychiatrists that I've worked with, and based upon studying the literature and looking at the work of other people. There may be different types of depression. So depression is not depression, if you will. And there is a range of subtypes of depression where what's happening in the brain and how it affects the body may differ. And if we can find new and advanced ways of identifying these different subtypes or phenotypes, as we call them, we can then tailor individual treatment to the person more efficiently and more effectively so they can be on the right track quicker and recover quicker.
What might these sort of subtypes of depression look like to an observer?
So the two subtypes of depression that we have studied here are called melancholic and non-melancholic depression. So the idea of melancholia has been around the literature, not just the scientific literature, but also the classical literature for many years. Melancholia is a syndrome where people have intense, what we call in psychiatry, psychomotor retardation. So it's like they are walking through jelly or glue. They are slow. They are flat. They don't show facial expressions. They seem, we use the word restricted or blunted in psychiatry. Things that normally make people happy and smile lose their effect completely in melancholia. So they experience almost no pleasure. People with melancholia also have lots of physical signs as well. Their sleep is terrible. They characteristically wake very early in the morning and feel worse at that time of day. And their appetite is terrible as well. They often lose a fair amount of weight during their depressive episodes. So it's more than just feeling sad, which is, of course, is terrible. It's these additional physical and somatic features that mark out melancholia from other types of depression. The importance of making this accurate diagnosis is key because it affects the type of treatment that you may offer somebody. Most forms of depression respond well to both medication, such as antidepressant medication, but also psychological and social approaches, which have a very significant and important role in the treatment of depression. So that may include seeing a psychologist or counselor and using cognitive strategies to change the way that you view the world and manage your stresses, and that is key form of treatment for many people with depression. But characteristically, people with melancholia have lots of physical symptoms and really don't seem to respond to psychological therapies. So the importance of making an accurate diagnosis of melancholia is that you would get people onto better treatment faster, because you can, as I said before, personalize their treatment. You can say, well, you have this very physical, somatic form of depression. You really need to be on an antidepressant. And if that's not working, we need to consider other medical treatments such as other forms of medication or even forms of brain stimulation, which are also very effective for melancholia. Things like transcranial magnetic stimulation using a strong magnet to change brain activity, electroconvulsive therapy, which does have a bad reputation in psychiatry but now is used very humanely and safely and is an effective treatment for melancholia, and also deep brain stimulation, which is an experimental therapy but one that our scientific group is very interested in bringing forward as another option for people with very severe melancholic depression. If you have someone with a non-melancholic depression, so a depression that is heavily influenced by social and relational factors, not associated with lots of these physical symptoms, you would say, well, look, you actually might be better pursuing social and psychological strategies to manage your depressive symptoms. You should look at the way you view the world and try and modify that through psychological therapy. You should look at the things in your life that are causing you stress, perhaps your workload, marital difficulties, perhaps the amount of alcohol that you're drinking, perhaps how much sleep you're getting, and look at all of these things which will have a big effect upon your mood. Medication may still have a role, but it's going to be a plethora of things that help you to get better. Whereas if you have someone with melancholia, they're often extremely sick, and if you make an accurate and early diagnosis of this syndrome, you can say, well, look, you have this very severe physical form of depression. We can still personalize your treatment, but based on the evidence that we have in medicine, you're more likely to get better if we really try and get you on relatively high doses of antidepressant medication. You may even like to consider some of these brain stimulation techniques, which will get you better quicker. We now have the scientific backing to show that these treatments are effective for depression and are safe. This kind of study that we've done and the techniques that we've used gives us further evidence that these two types of depression are different entities. I say this all the time, depression is not depression is not depression. Yes, depression is unified by the fact that people are sad most of the time or down most of the time and flat, but there are other significant differences in the type of depression that you may have, which ultimately changes what we might do about it to make you feel better.
So tell us about the study that you designed and how it might change things for these people with melancholia.
So we're lucky at QIMR Berghofer because we have this fantastic genetics group led by Professor Nick Martin, who studied and recruited the genetic basis of depression and have this enormous cohort of people with depression that live all around Australia. Professor Martin was very kind and allowed us to tap into his database, and we contacted all of these people with depression from around Australia, focusing on the people in southeast Queensland and northern New South Wales who could actually get here. And we said to them, look, we're doing this depression study. We're really interested in learning more about depression. Could you come and see us and talk to us about your depression and do a brain scan? And loads of people responded. We were really lucky. And so all of these people met with me, did a brain scan, watched a movie, which I can talk about more about in a second. And we were then able to what we call classify, so assign these people to whether they had a melancholic type of depression or non-melancholic type of depression. We did that through asking them very specific questions to identify what type of depressive syndrome they had. And again, to reiterate that people with melancholia have this very characteristic type of depression where they're sad for no reason. All of us have some stresses in our lives and some challenging periods. People with melancholia, they will be sad even when life is pretty good. People with non-melancholic depression tend to experience most of their depressive episodes in association with times of stress. So when they get separated from their partner, when they lose their job, those kind of things. And again, people with melancholia have this very physical type of cluster of symptoms, which is quite different from the characteristic subtype of non-melancholic depression, where even though people are still sad, it's still an awful thing to have, their mood can be lifted by positive things that go on around them, and they're not so physically slowed and flat and as I say again in psychiatry, blunted in their emotional expression. Previously, to try and identify these subtypes of depression, you went to see a psychiatrist, and your psychiatrist would ask you a lot of questions, background history from your family, look at all your old records, and try and make as good a guess as possible based on your previous history, as well as how you presented at that time, whether you looked flat, whether you were able to smile, whether you moved quickly or slowly, using that information to make a call about whether you had melancholic or non-melancholic depression. But what we wanted to do here was to use some more advanced techniques to ask, are there actually physical parameters based on people's movement that we can quantify to make a more accurate diagnosis? Also, because our interest in neuroscience, are there specific patterns of brain activity that show clear differences between melancholic and non-melancholic depression? Again, what we're trying to do is augment the diagnostic armamentarium to make an accurate subtyping diagnosis more efficiently, more quickly, so we can get people onto more effective treatment faster.
Can you give us a little bit of an insight, because it's a really ingenious study?
Yeah. The key differences between melancholic and non-melancholic depression is what we call in psychiatry psychomotor retardation, so a reduced number of spontaneous movements, slower movements, as if people are walking through concrete or stuck in jelly, a lack of pleasure, even to things that normally are enjoyable or humorous. So we did two things: meeting people and talking to them and getting a good standard psychiatric history about their previous episodes of depression and the symptoms they had and the medications they'd been on. We also did two novel things that we don't normally do in psychiatry. The first thing we did was we got all of our participants to watch a funny movie, and we chose the movie because it was PC, not rude or too challenging. It was a stand-up comedian, but we went through and trimmed all the not suitable for work bits, and we videoed people's facial expressions as they watched that movie. And so it was actually a very funny movie. It was a stand-up comedian called Ricky Gervais. Who
I approve.
Who's absolutely hilarious. We use a very sophisticated type of, we call it machine learning method, to deconstruct all of their individual facial movements as they watch this video. Then we put them in the brain scanner, the MRI machine, and we did what's called a functional magnetic resonance imaging scan. So not just taking a picture of the brain, actually measuring brain activity as they watched a different movie in the scanner. Again, though, a very emotional movie, quite moving. And we then were able to analyze whether people with melancholic or non-melancholic depression, so again, everyone's depressed, but whether people with these different types of depression differed in the way that their brains responded to this movie.
So now the findings are the exciting bit, Phil.
Thank you. We were pretty excited. The findings can sort of be split into two parts. Remember that we had this hypothesis that based on what we know about this melancholic syndrome, which has been described for centuries, people with melancholia move slower, think slower, react less. We thought that they would be less responsive to this humorous movie, and we thought that their brains would be less responsive to this emotionally evocative, moving short film that they watched in the brain scanner. And, drumroll, that is indeed what we found. So we closely looked at the facial movements of our participants as they watched this comedy, and we were able to deconstruct each individual facial muscle and its movement during each frame, each millisecond of this movie. And so we were then able to look at all the muscles in the face that we know are involved in smiling, and we could say, participant 1, look, clearly their smiling muscles are really active in the funny bits of this movie, and they're clearly enjoying it. They're displaying positive emotions. But participant 2, their facial muscles aren't moving at all. The ones that we know are involved in smiling, they're just not active. But the ones that are involved in frowning, wrinkling the brow, looking away, they're all more active. And so there's a difference here between these two participants. And then we went back and mapped out whether, in fact, there was a group difference between melancholic and non-melancholic. Indeed, there was. People with non-melancholic depression responded very nicely to the funny bits of the movie, and we could look at all the individual activity of their facial muscles, separating the ones involved in wrinkling the brow, moving the lips, dimpling the cheeks. And we found in this non-melancholic group, even though they were sad, even though they were still certainly depressed and suffering, there's no doubt about that, they could still be driven to a smile and a laugh by this very funny movie. However, the people with melancholia, although, based on just standard ratings of their symptoms, were no more depressed than this group, than this non-melancholic group. They were just flat and impassive. Their smiling muscles, brow wrinkling muscles, their cheek dimpling muscles were just dead, didn't move, no activity. That gives us a clear way of quantifying the difference there, just simply based on watching them through a video camera and running that back through our analysis pipeline there to separate those two groups.
What about the emotional movie?
Yep. So again, there was a clear difference in the way that the brains of these people with depression. So when the people with this non-melancholic type of depression watched the movie, their brain regions involved in making an evaluative judgment about the movie, whether it's happy, sad, moving, exciting, they were all active. But the people with melancholic depression, their brain regions involved in what we call the affective processing, so assigning whether a stimulus or an experience is good or bad, happy or sad, those regions of the brain were disconnected from regions of the brain in making a response to these stimuli or triggers. The regions of the brain that say this is good, this is bad, this is happy, this is sad, were just doing their own thing. Not interested, not connected, not part of a whole emotional system that detects and acts in response to what's going on in the world.
So brutal for a person, isn't it?
Yeah, dreadful.
So now the next step is...
So again, I'm a psychiatrist. I work every day with people with severe mental illness. So we really want to use this type of study to improve the personalisation of treatment for people with depression. Melancholic or a non-melancholic type of depression is still a devastating illness. So it's not as if melancholia is necessarily a more distressing type of depression. So people with non-melancholic depression suffer just as much, but it's about finding the right treatment. So if you've got someone with non-melancholic depression, you can now backed by science, you can say, well, look, these are the treatment options for you: medication, psychological therapy, addressing social issues that may be contributing to your depression. All of these things will be valuable, and you should pick the one that best suits you and your lifestyle and your preferences. But if you've got someone with melancholic depression, well, we can now accurately make this diagnosis. We're very confident that you indeed have this very severe biological type of depression. Look, there are other options, but really, based on what we know about this type of depression and what we know about the best treatments for this type of depression, we'd really recommend looking at some of the biological therapies, whether that's antidepressant medication, whether that's brain stimulation techniques. That's more likely to get you better quicker and get you functioning again.
It can be lethal, can't it?
Yes, that's obviously the worst possible outcome, yeah. Even with people who don't reach the stage of considering whether their life is worth living or not, they're still suffering immensely. They're not enjoying life. They're flat. The people around them also are affected by their flatness and lack of enjoyment and lack of engagement in the world. So it's an awful illness.
I'm sure there's someone listening now that's saying, that is me, or that's someone I'm living with or someone I care for. Yeah. The thing to do now, if you think you have melancholia, is to get your GP to refer you.
Yes, most definitely. We recognise that it might be difficult to get in to see a psychiatrist. Definitely go and talk to your GP, and they will know the psychiatrists who are local to you, and they may have some recommendations about the best fit for you, given your personality and your background. The Royal Australian and New Zealand College of Psychiatrists, bit of a mouthful, or the RANZCP for short, on their website, they also have a a searchable directory of psychiatrists. I'm on there, for example, where you put your postcode in and it tells you all the psychiatrists that are within a spread of kilometres from your location. So that's another way to find a psychiatrist. These methodologies, or the types of ways that we've classified these two different types of depression in this study, might not be something that you can walk into your GP and access now. The take-home message of this study, it reinforces what we've been aware of in psychiatry for some time. Again, coming back to that phrase, depression is not depression is not depression. There are subtypes of the depression. They're different. They have different expressions in terms of what symptoms you might have, but they also have differences in terms of physical and biological parameters that we can detect and measure, both in terms of your movement and your brain activity. So it gives greater backing to the idea that we should be trying to subtype depression, and psychiatrists can do this. You don't have to do the brain scan and do the facial imaging analysis. That's what we've done in this study to prove that there are true differences, but you can still go and see a psychiatrist who can make an accurate diagnosis of melancholia based on your current symptoms, your previous response to treatment, and also, of course, your family history as well, which is an important thing to consider.
And it really leans into the study that your group does as well with deep brain stimulation, and the research that you're doing and will do shows that can be really effective for this subset of people as well.
Yes, step one, we've shown there's a clear difference biologically between these two groups of people with depression, even though based on standard assessments of symptom burden, they're both equally severe. There's a clear difference. Can that then translate into better outcomes if we personalise their treatment? My clinical experience tells me there will be, but we've got to prove it. Can we show that this leads to better outcomes?
And Phil, you've seen this, somebody with melancholia getting the right treatment from the right person at the right time. How does that look once they come out of it, and how is their response?
Melancholia is just awful. So it's almost like a Lazarine recovery that people show. So they seem to sort of wake up. They become responsive again to their family. They start to move more freely again. They smile spontaneously. And it's fantastic when they recover from this.
Is that the best part of your job?
Yeah, it's good. It's great. It's a really meaningful outcome.
We talked a bit more about deep brain stimulation in the last pod with Dr. Phil Mosley. If you'd like to find more about that, go and have a listen to that podcast on OCD. And if you would like to know more about Dr. Phil Mosley and his team and their work, or donate to their further work, go to QIMR Berghofer.edu.au. Thanks, Phil.
You're welcome.